Hello, everybody. Thank you for joining us today for our Maintaining Brain Health and Preventing Dementia lecture. Dr. Michelle Chen is Assistant Professor of Neurology at Rutgers University. She is a clinical neuropsychologist and evaluates patients' cognitive functioning in order to determine the presence of neurodegenerative diseases and offer treatment recommendations. Now we welcome her and give her the floor. Thank you.
Hi, everyone. Thank you for coming in person as well as anyone who's on Zoom. So today I'm going to be talking about, I'm going to give really an overview of, what dementia is and some strategies in how to optimize your brain health. And, as the introduction said earlier, I'm a clinical neuropsychologist. So what that means is that clinically, I evaluate people's cognitive functioning. They come in, they maybe have some memory concerns, and then I do an evaluation to see whether is this something that's normal aging, which there are some decline that's associated with normal aging, which we'll discuss, or if there's a presence of any more insidious neurodegenerative condition that we might be concerned about. I also do a lot of research at Rutgers University, which I will talk about a little bit in the end. We also have materials there that you can take a look at on your way out if you want. Well, let me just advance my slides. So these are some of my funding sources for my research, but most of it is our governmental and agencies and nonprofit organizations and also Rutgers University. So there's no conflicts of interest that's in relation to this presentation. So like I said, today, I'm just going to talk about what does it mean to have cognitive decline and what does it mean with normal aging versus something that's more of a disease pathology. And I will talk about some common brain diseases and syndromes because I think when people talk about dementia, they don't quite know what that means and what's causing it. And also they think of it as one thing when it's really a syndrome, which means it's kind of a collection. It's really symptoms that can be caused by multiple diseases. So I will just briefly talk about some of the most common diseases, as well as how we assess and treat them. And then in the end, I'm going to talk about different strategies to maintain brain health that we can all do now. And I would like to say that, optimizing brain health is not something that you should just do as you get older, but it's something that you can really do lifelong because we know that there are so many risk factors that are really important in the early life and also the midlife that can later on lead to dementia and cognitive decline. So it's really important to really start as soon as you really are aware of them. All right. So in terms of cognitive decline, so we kind of have three, I kind of put them in three different buckets here. The first one is normal aging. And that just means that as we age, just like other parts of your body, all your organs, they do deteriorate as we age. And the same thing happens to the brain. The brain does deteriorate when you age. So normally, even when you don't have any disease, as you age, you are going to experience some cognitive decline. So, when you're going to be in your 60s and 70s, you're not going to have the same memory that you had when you're in your teens or your 20s or 30s. So that's something that occurs normally. But there are diseases that can impact your brain that can so you would decline much more rapidly than other people of same age. And there are two different categories I would put them into. One is a more mild condition. It's called mild cognitive impairment or mild neurocognitive disorder. There's different nomenclatures that we use nowadays, but it just means like it's the mild stage. And that means that you have some modest cognitive decline and your everyday activities now maybe require more effort than before. So maybe you need to write things down a lot more. You need a lot more reminders. But you can still do everything yourself. Like if you're living by yourself or you have to do things by yourself, you can still do it, even though it's greater effort. And at the point when it becomes that it's very significant decline where you require assistance from other people to help you with activities. Let's say if you're managing your medications, you can't remember to take your medications every day, even with your strategies, you need someone to help you, or you have trouble remembering to like turn off the stove, and like many things where now we are concerned about you living by yourself. In that case, then that would be kind of more in the dementia bucket. So that's kind of the general distinction between them. And, in our exams, we also try to quantify cognition too, to see, which range are you most likely in as, and also accompanied by, how you're doing in your everyday life. So there are different common brain diseases and syndromes that affect, that can cause dementia. So these aren't all of them, but these are the most common one I'm just going to briefly touch upon. I think a lot of people have heard of Alzheimer's disease and they think dementia equals Alzheimer's disease. And in a way that it's kind of true that Alzheimer's disease is the most common cause for dementia, but it's not the only cause. So there are other types of dementia, such as vascular dementia, which relates to our blood vessels in the brain. There's Lewy body disease that includes another kind of proteins that accumulates in the brain, and also frontal temporal dementia, which again involves other kinds of proteins that affect certain areas of the brain, specifically the frontal and temporal lobes. That's why it's called frontal temporal dementia. And I'm just going to briefly cover each of them so you kind of know that there are some differences, and these are, my things that you want to be looking out for, either for yourself or for other people that you know. All right, so Alzheimer's disease, as I said, is the most common cause for dementia. So it's really a product of buildup of abnormal protein fragments and tangles in the brain called amyloid beta fragments, as well as tau tangles. And these two types of pathologies, they kind of act together and cause this cognitive decline that we're talking about, that can cause dementia. Currently, 6.2 million Americans have Alzheimer's disease, and this number is expected to increase because of increases in population. So by 2050, it's anticipated that this figure will reach 13 million people in the U.S. who will live with Alzheimer's disease. And I list the symptoms here. So the most prominent hallmark symptom for Alzheimer's disease is memory loss. So specifically, it's the ability to learn and retain information and kind of make that into long-term memory. So some people, they might be able to learn the information in the short term, but later on, they would forget the information after a period of time. And at least in the beginning of the disease, usually very memory that are from a long time ago, that's not usually lost, especially in the beginning of the disease. I think some people think of memory as like, oh, I have good memory because I can remember things that happened to me when I was really young. And those kind of memories, they don't disappear very easily, even with people with severe brain injuries. Like those memories are usually things that, because they have already been wired and they've been recalled so many times, that it's very strong in your brain. So they're not really likely to be lost until like really advanced disease. Whereas the ability to learn new information and remember them, that's really what we're most concerned about as early signs, because so those memory systems are really vulnerable to these kind of disease pathologies. Besides memory, people might have language problems. So a common sign is not being able to come up with the word that they want to say, which can also happen quite often with normal aging, but just at a higher frequency for people with Alzheimer's disease, as well as they might have difficulty comprehending other people and expressing what they want to say. They might have difficulties with doing really complex tasks, such as problem solving, having good judgment, planning and organizing. Those are what we call executive functioning, which are these really complex tasks that the front of your brain, the frontal lobe, does. And those can also get affected, as the disease progresses. Some people with Alzheimer's disease, they can also have this atypical presentation where the first sign is actually the ability to process visual information that's being affected. It's called posterior cortical atrophy. It's kind of an atypical presentation of Alzheimer's disease. It's caused by the same disease, but it's affecting the back of the brain first. And that's where you're processing all this visual information. So for some people, that might be really the first sign. And for those individuals, sometimes it can really get missed because some people might think that this is more of an eye or an ocular condition when it's actually a brain condition. The thing about the brain is that because it controls so many functions of different organs, that it's hard. It might be hard to know in the beginning, especially for like a primary care physician where there might not be experts in these particular disorders. They kind of think that, oh, maybe this is due to another organ system like the eyes, when it actually is a brain problem. And as the disease progresses, then the person might have episodes of disorientation, and then they might wander and get lost. So usually this is when, well, actually, hopefully before this is when you really, thinking about stopping to drive will be really important. And if they're really, if it's really advanced, like even in the home, they can go out and wander off. So then having family members supervise them, or having systems in place to make sure that people aren't going outside and getting lost by themselves will be really important. So vascular dementia is arguably the second or third most common cause of dementia. It really depends on which papers you read and how they define this. But basically, the most common cause for vascular dementia is reduced blood supply to the brain. So there's some kind of blockage in the brain vessels, blood vessels, that stops oxygen from going into the brain. Your brain needs oxygen and nutrients. Those are like the two most important things it needs. So when the blood supply is cut off, either it can be due to a stroke. When you have a big stroke, that's really a very sudden, like a complete blockage of a major blood vessel that causes symptoms such as numbness on one side of the body. So very common is numbness in one side of the face and one side of the upper extremity. Sometimes it can also affect the lower extremity, depending on which blood vessels are affected. So when you have multiple strokes, that's a major risk factor for developing vascular dementia, because your blood vessels are kind of being damaged along the way. And then not just, and after the blood vessels are clogged, it's going to stop oxygen from going into different brain cells that really need that oxygen, and those brain cells can die, right? So that's a very major common risk factor for vascular dementia. But even if you don't have a major stroke, sometimes you can have smaller strokes that maybe you don't experience a symptom, but for some reason, if you get an MRI, they might say, oh, maybe there's some small strokes in the past that is shown on imaging, even though you didn't experience symptoms. Or some people, they might not have any strokes, but there can be a buildup of plaques on the walls of the blood vessels. And also as you age, depending on which health conditions you have, your blood vessel can also get weakened. And then that kind of causes narrowing of the blood vessels that can also reduce the blood flow to the brain. And that's oftentimes people who have lots of conditions that affect the blood vessels. Just think of them like conditions that affect the heart. Anything affect the heart can affect the brain. So things like high blood pressure, high cholesterol, diabetes, obesity, these kind of conditions can all cause problems with the vascular system, your blood vessels, and hence would be risk factors for vascular dementia. So these are kind of the most common kind. You can also get strokes and vascular dementia from bleeding in the brain as well, but that's usually a less common than just blockage of blood vessels. And then in terms of symptoms, it really depends on which blood vessels are affected. So if you have strokes, then if it's affecting, let's say, the left side of the brain, it could affect your language abilities. It can also affect motor functioning on one side of your body. Or, if it's certain parts of the brain that are most affected, then it can affect different areas that are those brains kind of help function. But what we see very commonly is that they can get a lot slower in terms of their ability to process new information, and also difficulties with doing the complex tasks that we talked about before with executive functioning. So again, things like judgment, problem solving, planning, and organizing. Those things can definitely be more difficult. And then we also see memory difficulties with vascular dementia as well. But although it sometimes looks a little bit different than something that we see with Alzheimer's disease, Whereas in Alzheimer's disease, the most common is really that you learn this information and you lose the information over time. It just gets lost. Whereas, and then even if you give them a hint, they can't, the information is gone. Whereas oftentimes the vascular dementia that we see is that it's really the ability to come up with the information that's difficult, but it's not that the information is lost. So sometimes with hints or cues, even though they can recall it spontaneously, they can still be reminded of, oh, wait, this is what happened, once you give them a little bit of a cue. So that's kind of like a more minute distinction between kind of the different kinds of memory difficulties we see. And then these differences, I would say that is really most obvious in the early stages. Once someone becomes more advanced, then they're most likely going to be much more globally impaired across multiple areas of cognition. So at that point, it'll be kind of hard to tell just from the symptoms. So there might be other diagnostic tests that would have to be done to really be able to distinguish between these different types of diseases and syndromes. And then Lewy body disease, again, is arguably the second or third most common. So I think vascular Lewy body, they're really neck and neck in terms of the next most common cause of dementia after Alzheimer's disease. So in Lewy body disease, it's also due to a buildup of abnormal proteins in the brain. It's different from the Alzheimer's disease one, where you see the beta amyloid and tau. In this case, you're seeing alpha-synuclein depositions. These are the same types of proteins that also cause Parkinson's disease. So Parkinson's disease and Lewy body disease are actually really coming from the same kind of abnormal proteins in the brain. It really just depends on where part of your brain and spinal cord that they're affecting, and the symptom and the course that's different, but it's really from the same kinds of proteins. And that's why a lot of times people can get misdiagnosed. They might have Lewy body dementia, but then initially they might be diagnosed with Parkinson's disease. But then once their progression of cognitive decline is a lot faster, people realize that this is not just Parkinson's disease. It's actually dementia with Lewy bodies, which would be a much faster course in terms of decline in your thinking and memory abilities. So some of the hallmark symptoms that we associate with Lewy body disease are fluctuating attention and alertness. So it can be that from day to day, or even sometimes hour to hour, where sometimes they can be very alert, and other times they can be, really hard to pay attention, and they can, be kind of not being, really with you in conversations. Visual hallucinations is something that's also commonly seen with Lewy body disease, where they can see things or animals that are not really there. And it's very different from the kind of visual hallucination they would get from a psychotic disorder, such as schizophrenia, where in schizophrenia is actually, visual hallucination is actually not that common. It's actually more common to hear voices. It's actually more common to have auditory hallucinations. And it's usually like very scary. It's always telling you something negative about yourself, and maybe you try to hurt yourself, hurt other people. And it's very, it's very distressing for a person with schizophrenia. And usually that onset's much earlier. It's usually in late teen to early adulthood. And it's very uncommon to have an older person suddenly having psychotic symptoms in older life without any prior psychotic episodes. So usually in that case, we would think, oh, this is probably more of a brain disease problem than schizophrenia. Whereas dementia with Lewy bodies, the visual hallucinations is usually of people and animals, and it's not usually very distressing. A lot of people say that they see maybe family members who have passed away, or animals like maybe ants crawling on the wall when it's not really there, like things like that. It doesn't usually get particularly distressing for people. REM sleep behavior disorder is another common sign for Lewy body disease. So not going to get into too much of like the physiology of sleep, but basically there are different stages of sleep. And REM, or rapid eye movement, is a stage where there's actually a lot of internal arousal that's happening inside the body, but then your body is like very, very still. And this is usually the stage of sleep where you experience most of the dreaming. You do most of your dreaming during REM sleep. And if you have REM sleep behavior disorder, that means you're actually acting out your dreams. So you're moving a lot. So normally during this stage, you're very still. You're almost like paralyzed. Whereas people with restless behavior disorder, there's not that inhibition that your brain does to your body. You're actually moving, and you're kind of moving and acting out your dreams. So that's why sometimes doctors might ask you, whether you move in your sleep, do you injure your bed partner while you're sleeping? Because that might be signs of restless behavior disorder. And then Lewy body disease, because it's caused by alpha-synuclein depositions in the brain, you can have very similar motor problems that you see with Parkinson's disease, such as slow movement, being unsteady, having tremors. Although a lot of times these motor problems don't exactly line up like the classic Parkinson's. That's why usually when clinicians will be concerned about maybe this is atypical Parkinsonism, and it can be other types of diseases like Lewy body dementia. And then in terms of cognition, again, difficulties with processing visual information and complex tasks are often seen with Lewy body disease, as well as processing information slowly that we see in this. And then the last one I want to talk about, again, another very much more common syndrome than others that I didn't include in this presentation, is called frontal temporal dementia. And what's different about this from the ones we've talked about is this is actually more likely to have an earlier onset. So the other types of dementia I talk about, maybe I think once you get to 60, 65 and above, that's when it's much more common. Whereas for people in their mid to late 40s or 50s, they're actually right in the onset of frontal temporal dementia that we might see. And it can be caused by different abnormal proteins that occur in the brain. Some types of frontal temporal dementia can be caused by Alzheimer's disease pathology. Some can be caused by other types of proteins that are affecting it, really depending on which variant it is. So I'm not going to go into too many details into it, but there's basically three main variants. One is a behavioral variant of frontal temporal dementia, which would most likely affect people's behavior and personality. So if people start to do things that they normally wouldn't do, especially things like now they're doing things or saying things that are really inappropriate, and it's not things that they normally would have done before, that's a really alarming sign that maybe something neurological is going on. So that's kind of the behavioral variant when there's that really marked change in their personality and behavior. There can also be a variant that affects language mostly. It's called primary progressive aphasia. And I think recently we've had celebrities like Bruce Willis who has had this disorder. So people now have a little bit more knowledge of it, but it primarily affects language. And then it can be to the point where it's really hard for people with primary progressive aphasia to communicate with other in terms of either saying what they want to say or being able to comprehend what other people want to say. Or they can be very fluent, but then what they're saying actually doesn't make any sense. So that's a very I would say it's not a super common condition, but I think it is, getting more, people are getting kind of more knowledge of it because of some of the, mainstream news that are happening. There's also motor variants of frontal temporal dementia that I'm not going to get into, but they can involve abnormal movements of your arms and eyes and different things like that can be caused by different, depending on which specific pathology that can cause the frontal temporal dementia. So in terms of how we assess for dementia, we usually get a history of symptoms. Usually from family members and the patient together to really get a sense of like what kind of specific symptoms that they're experiencing that can help us first of all, to determine whether there might be a dementia process going on or starting to going on, and also what kind that we might be thinking about. And then usually you would want to go for a neuropsychological or neurological assessment, usually both, to really assess different areas of cognition and motor and sensory and other areas that might be relevant. You might also get a lumbar puncture or a spinal tap to get proteins in our cerebrospinal fluid. So that's the fluid that's basically is in our head that surrounds the brain as well as surrounding our spinal cord. And so so obviously we don't want to directly go into the brain. So usually this fluid is obtained by getting that fluid from the spinal cord. And that can tell you At least with Alzheimer's disease, there's biomarkers that we can use, that we can see whether, it's likely to be due to Alzheimer's disease pathology or not. For the other types, we don't really have very robust biomarkers as of this point in terms of scientific advancement. In terms of neuroimaging, we can also get the same Alzheimer's disease biomarkers through PET scans. Though that's done more frequently, I would say, in the research setting, because in the clinical setting, it's getting the cerebral spinal fluid from lumbar puncture is still more of the gold standard, but some places you might be able to get a PET scan too. That's a little bit less invasive, but there's still some degree of invasiveness though, because usually there's a radioactive tracer that you have to ingest first before the PET scan in order for them to trace the molecules that they're trying to track. You might also go through CT and MRI scans that basically take a picture of your brain and look at the structure of your brain. It's not going to be very definitively diagnostic of specific dementia syndromes, but it can get information like maybe areas that would subserve the function of language is much more affected, or there's a lot of vascular disease like that occlusion of the blood vessels that we talked about that can also be seen, especially if it's more in the moderate severe range. It can really be seen on MRI. So that's something that we can that people can take a look at. Currently, unfortunately, there is no cure for dementia. Many of the diseases that we talked about, there is no cure. There's nothing that will just treat you and then you go back to normal. There are medications that are available. So up until really the last couple of years, most of the medications are more symptomatic, meaning that they mostly target specific hormones and chemicals in the brain and try to increase that so that it can help you with your memory and learning and your cognition. But it's not really treating the disease. The past couple of years, we have had now new medications where it's actually going to modify the disease. And this is, and it's just in Alzheimer's disease. And there's just more research with Alzheimer's disease. That's why we just know more about Alzheimer's disease than others and have more advancement in this. So now we actually have disease-modifying therapies for Alzheimer's disease. You might have heard of Leqembi or Kisunla. Before there was also Aduhelm, but now it's being discontinued. So these are supposed to modify the disease course, so it slows down the disease. But there is no evidence right now that they can really reverse any symptoms or even get back of your functioning. It's really just meant to slow down the disease. And it's only really demonstrated to be effective to do that in very early stages. So once you get to later stages, right now we don't really have evidence that they will really make much of an impact. There's also other types of non-pharmacological treatments that won't actually treat dementia, but can help people function better in their lives. So there are cognitive rehabilitation therapies where people can learn how to implement strategies to help them remember better. They can work with families on how to best communicate with your loved ones if they're really having very significant language impairment. Occupational therapy can help people identifying assistive devices that work best for them, help them ambulate, like walking, help them eat, and different things. Physical therapy can help them. They're having a lot of motor issues. If you have a neurological motor issues, with exercise, usually it's recommended that you work with a physical therapist that knows how to work with people with these conditions, because even though we say like exercise is good for you, which I'm going to get to, you also want to make sure that you can do it safely. And then speech and language therapy are also available for people, again, with the severe speech and language problems that they can help you with communication strategies. And sometimes people have difficulty with swallowing when they have these motor symptoms. They can also kind of help with that as well. So in terms of the genetic components of dementia, so there's definitely hereditary forms of dementia where there's a very specific gene that we know that, it causes, dementia in the people with this gene, maybe like 50% out of 10 or something. And usually it's like a very specific genetic variant. Those are very, very rare. Most of the cases of dementia are not due to these genetic variants. people can have also other genes that can be a risk factor. So ApoE allele 4 is probably the most common risk genes that people talk about, where if you have 1 or 2 copies of that, it doesn't put you at greater risk of developing dementia, but it's not like a genetic variant where it's almost inevitable, or you have this long family history, everyone has this genetic variant. But just by having a family history of dementia does put you at slightly higher risk. Although I think nowadays with dementia being, kind of being more commonly seeing than before, that I think a lot of people are going to have some family history of dementia now. So it's not going to be, I think, very predictive necessarily of whether someone develops dementia. And what I really want to talk about in this last part of the presentation is that we know that 45% of dementia cases worldwide can be attributable to lifestyle factors. So even though there are certain genetic predispositions, which we can't really do anything about, right? There are things that we can do to live healthy lifestyles that help us have better brains, or at least trying to optimize our cognitive functioning for as long as we can. And the goal is really, if you can try to do these things and delay the onset of dementia to after your life expectancy, then that's really the best. Then you will never develop dementia in your lifetime. And we actually see that in autopsy studies where they look, cut open people's brain after they die, and they see that there are people with, let's say, Alzheimer's disease or other disease pathology, but they were never diagnosed with dementia while they're alive. So those are the kind of people that we really, as a scientific community, really want to study, like what makes them more resistant to disease pathology, so that they can actually kind of live their life normally, even though there are this kind of brain pathology that's going on. So these are some of the things that, from a big volume of research, are things that we know that are good for cognition. So one thing is that you want to maintain your physical and mental health. So earlier I talked a lot about how strokes and these blood vessels are really important to maintain. So preventing strokes is really important. So things like, again, high blood pressure, high cholesterol, diabetes, obesity, and smoking. These are all things that can affect the blood vessels, which affect heart conditions, as well as, in this case, brain conditions. That's really important. Certain thyroid conditions can also affect cognition as well, not in the same kind of vascular sense, but just it can also affect your cognitive functioning. And then mental health is really important. We know that depression is actually also one of the risk factors for developing dementia later on. If you have a history of depression, especially untreated, it's especially bad in terms of later cognitive outcomes. So if you have these conditions, I would say that, the recommendation is I make sure they're treated well. And if there's anything you can do to prevent them in the first place, will be good to do. So that kind of leads to the second one, which is exercising and eating healthy, because those can help prevent a lot of these vascular risk conditions that we talked about. So aerobic exercises and exercises that engage both the mind and the body, and also even resistance training, we know that these do have some evidence behind them in terms of people who engage in these activities have a lower risk of developing dementia. And if you have any deficiencies, there are certain types of vitamin deficiencies and other deficiencies where it can also cause not necessarily dementia to like that severe of an extent, but it can cause cognitive issues. So things like vitamin D, B1, B12, like these are all the things that usually your doctors would kind of watch out for and then test for periodically, especially if you're having memory or cognitive concern. There are also specific diets that have some research behind them in terms of helping to be protective against dementia. So there's like the Mediterranean diet, DASH diet, MIND diets, and I think we have a handout here on the MIND diet that you can take a look if you want. But basically all of these are saying similar things. It's about like eating lots of vegetables and fruits, whole grains, healthy fats, not trans fat, and reducing red meat. And specifically for the DASH diet and also the MIND diet also kind of focuses on reduction of sodium intake, because that can affect effectively these kind of blood vessel diseases. But I would just say, like, in general, just kind of, what you would know normally, what to do to eat healthy. Just do that. Because sometimes, I think just adhering by a certain diet is not necessarily going to be super helpful, at least strict adherence, but just knowing what are the general recommendations and kind of trying to adhere to the spirit of that is probably the most important. And then these are some other recommendations, from research that we know are good for the brain. So social contact, is really important because social isolation leads to negative cognitive outcomes. And this is especially important as people get older, when they might be retired. A lot of their friends, maybe their spouse have passed away, or maybe their children or live far away, or they don't have children. Like, now their social network is a lot less than before. And that's actually something that is we know that that's not good for the brain at all. So constant social interaction is really important. So if you come to the library here, that means that you're trying to have that social contact. And that's just really important to maintain, especially as people age. Cognitive stimulation, which means that you want to exercise the brain. So kind of like what this image is trying to do, like a little brain doing exercises. The brain is basically like any parts of your other body, right? Think of it as a muscle, right? If you want to maintain your muscle, you need to work out and work at it in order to strengthen it. Same thing with the brain. So you need to work on your brain to strengthen it. So doing things that are cognitively challenging for you, like learning a new hobby, learning a new language, engaging in puzzles that are really difficult and challenging for you. Like, if you feel like you're doing an activity and you in the end, you kind of feel like, this was kind of really cognitively taxing for you. That's good, because that means like you're really trying to strengthen your brain. And what that does is it strengthen the connections between different brain cells, which are really important in terms of maintaining their function. Having good sleep is really important. We know that sleep deprivation, especially chronic sleep deprivation, is bad for cognition. And you might experience this on a day-to-day level, where sometimes we just don't have good sleep. Next day, it's very hard to think sharply, and you feel kind of groggy, right? So that's kind of the short-term effects. But in the long run, it's also bad for your brain. So making sure that you're sleeping at least 7 to 8 hours per night. If you have lots of sleep disturbances, then speaking to your providers about ways to help with that. Just be mindful of medication, because a lot of the sleep medications do have side effects. So it's really kind of, making sure that you're minimizing the side effects, but still trying to improve your sleep. There's also behavioral strategies to help sleep that you might want to talk to with your providers. Alcohol and other drug use is something that should be reduced, and really eliminate it. Is especially alcohol is really is probably the most optimal, but for some people, it might be hard to completely eliminate it. So I would say, like, really making sure that it's more minimal is important, because these are all things that can affect the brain. Like alcohol, for example, is a neurotoxin. That's just what it is. So even though some people might enjoy some of it, and some slight amount might be okay, but in the long run, it does damage your brain cells. And for people with chronic alcohol use and dependence, there are actually specific syndromes that we see that affect people's cognition, their movements, their eye movements, that are related to vitamin deficiencies because of the alcohol use that can lead to very profound amnesia and dementia. Head injuries is another risk factor as well. So preventing head injuries, making sure if you have a head injury, again, seek medical attention first of all to see whether there's anything that's really urgently that needs to be treated, and later on, trying to make sure that your brain fully recovers. Wearing hearing aids is really important. We've recently kind of know from research that hearing loss is a risk factor for dementia. And there's different hypotheses on why that might be. I think the actual mechanism we're still trying to really uncover. But one of the things that people with hearing loss experiences is that now they have a reduced ability to interact with the world. If you can't hear, then you can't really interact with other people and really engage mentally really well. So that might be one of the pathways in which that hearing loss can affect cognitive outcomes. So where hearing is actually, we know that that can reduce some of that risk. Vision loss also recently has been identified as another risk factor for dementia as well. Some of it could be for similar reason as kind of the hearing loss things. And also there are also direct connections between the visual system and our brain systems that might explain this too. So if there's any modifiable vision loss issues, addressing them, such as if you have cataract, getting cataract surgery, if you need glasses, get glasses. Those sort of things are important. And then finally, air pollution is another thing that can negatively impact brain health. And I think that might be even more salient in certain parts of the country with more air pollution or other parts of the world. But in general, just we know that air pollutants are not good for the brain. So just, try to minimize exposure to that if you're able to, would be recommended. And then this is just a brief summary. I want to make sure we have some time in the end for questions. But basically, a sign of cognitive. So we talked about cognitive decline and what's normal aging and what's beyond normal aging. And it's hard to kind of say what is one sign that it's, this is beyond normal aging. Usually you do want to see a neurologist or neuropsychologist who really kind of tease this apart. But I would say that if you feel like everyday activities require greater effort or even assistance, then that might be a sign where this is not just normal aging. There's many diseases that can cause dementia. Alzheimer's disease is the most common, but there's also other types that we talked about. Currently, there are no cures for dementia syndromes and diseases, and there are also really no treatments to improve symptoms. There are some medications now that we can modify the disease course and slow down the disease, but nothing can actually reverse the disease and improve symptoms right now. So that's why the most important thing is to try to modify your lifestyle behavior in order to help delay the onset or prevent some of these diseases. So, among the things we talked about are maintaining your physical and mental health and also being physically, socially, and cognitively active. All right, so that was kind of the end of the didactic part. I just want to bring to your attention that, we do research, and two of my students from my lab are here today to kind of help. But we have a number of research opportunities that we have some flyers on the table over there. You want to take a look. We also have handouts that kind of go along with some of the lifestyle things that we talked about today that you can pick up on your way out. But basically, you have two main studies. One is on multiple sclerosis. So if you have multiple sclerosis or if you know people with multiple sclerosis who are age 50 plus, you can refer them to our lab because we are trying to study these lifestyle behaviors such as exercise and diet that we talked about today, but looking more specifically at people with neurological conditions such as MS, because most of this research is really done in people without these prior history of neurological conditions. So we want to know more about what happens if you already have an existing neurological condition. And I have a QR code here for just a link to our website. We also have our cards over there if you wanted to pick it up. And then another study that we're doing is on long COVID. We're recruiting individuals who have persistent fatigue after they already recover from the COVID-19 infection for months. And then what we're doing is we're trying to see whether we can measure fatigue using a smartwatch, because fatigue is something that's very subjective and hard to measure. So that's just something that we're doing. So these are some of the research that's going on.